The topic for this session is orofacial pain. This is a core topic for a dentist, and in addition to this PowerPoint presentation with voiceover, I've also uploaded a PDF copy of the presentation on the DLE, and you should be able to download it. The aim of this session is for you to gain an understanding of conditions responsible for pain in the orofacial region, and by the end of the session you should be able to discuss the following aspects of orofacial pain: the causes of pain, both odontogenic as well as non-odontogenic, the presentation of different disorders responsible for pain in the orofacial region, and based on this clinical presentation, you should be able to develop a differential diagnosis for management of your patients presenting with different disorders. And finally, we shall briefly touch on the management principles of orofacial pain. As you know, pain is one of the most common presenting symptom in dental practice. And in fact, when members of the public think about dentistry, the first thing which comes to their mind is pain. It's something you would be dealing with routinely in your dental practice every single day. Uh, as you would know, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And you would have learned in your previous sessions about the physiology of pain, such including um, the causes of pain, the chemical mediators involved, the different pain pathways in the head and neck region, particularly those related to the trigeminal nerve, and different theories which uh, are responsible for um, pain transmission in the head and neck region. Um, so that's not the topic for this session, but you may want to consolidate those elements at this point. So coming back to the topic, the first step in the management of pain is to determine its cause. So odontogenic causes are common, that is tooth-related causes are common, and as a dentist you should be able to recognize, assess and manage odontogenic causes of pain. Non-odontogenic causes of pain are uncommon but very important because they may be indicative of a more serious underlying disorder which warrants referral to specialists in secondary care. And as a dentist, you should be able to recognize and refer non-odontogenic causes of uh, pain in the orofacial region in the best interest of your patients. Dental disease constitutes the commonest cause for pain in the orofacial region, and over 95% of patients who present with pain in your routine clinical practice will often have a tooth-related cause. So thinking about the commonest cause of pain from the teeth, dentine sensitivity as a result of tooth surface loss, and then pulpitis either secondary to caries involvement or trauma, iatrogenic damage, periradicular lesions such as apical periodontitis, and infected periradicular lesions such as a periapical abscess, granuloma, or a cyst. And then also you have to think about different types of cellulitis in the maxillofacial region. In this image, you can see periorbital cellulitis in a child, but also in adults, you have to think about submandibular cellulitis, as in Ludwig's angina. And by this stage of your course, you should be able to identify and assess all these forms of tooth involvement, dentine sensitivity, pulpitis, periradicular lesions, cellulitis, and just to remind you that response to pulp sensibility tests are crucial to diagnose pulp disease. So with any form of pulp involvement, you would probably expect a negative response to pulp sensibility tests. and you should be able to either manage all these conditions yourself, or you should be able to refer them appropriately to secondary care. The second commonest source of odontogenic pain is the periodontium. Common conditions which can lead to pain are pericoronitis around partially erupted third molars, uh, periodontal abscess, which we'll see in the next slide, necrotizing periodontal disease, and HIV-associated periodontal disease, which is fortunately not so common now because of improved antiretroviral therapy. But the hallmark of HIV-associated periodontal disease is rapid bone loss and um, nocturnal pain. This image shows an acutely inflamed buccal swelling related to the uh, right maxillary canine, and a periapical radiograph shows extensive bone loss and radiolucency related to the canine. Now, if on clinical examination you are able to express pus from this swelling, and if the swelling is fluctuant, then you are quite likely to be dealing with an abscess. Now, to differentiate whether the abscess is of periodontal origin or periapical origin, the most crucial factor would be uh, pulp sensibility tests, because pulp is likely to be non-responsive with periapical abscesses secondary to pulpitis, and it may still be vital with um, a periodontal abscess. Another common source of facial pain is the temporomandibular joint and the masticatory muscles. This is something we've discussed in case 3.6 recently, and I would suggest you to consolidate your learning on this topic. Pain from the temporomandibular joint and masticatory muscles may present as myofascial pain, internal derangement, arthritis due to a variety of causes, including osteoarthritis, rheumatoid arthritis, and trauma to the temporomandibular joint. The jawbone is a common source of pain, and a variety of pathological conditions associated with the jawbone may present with pain. The most common and the most recognized is alveolar osteitis or dry socket. Obviously, in such cases, there would be a history of tooth extraction, even though it isn't a topic for today, but I'll just highlight a few important points. The pain associated with dry socket usually starts 24 to 72 hours after the tooth extraction, more precisely 48 to 72 hours. And on clinical examination, you would identify exposed necrotic bone, halitosis, and an empty tooth extraction socket devoid of a blood clot. Soft tissue swelling and systemic features such as fever, malaise, lymphadenopathy are not marked in dry socket. So it's basically a healing defect, even though it may get secondarily infected. Uh, it's not an infection per se. So the management involves irrigation of the socket with saline and dressing it with an analgesic uh, preparation such as alveogel. The important thing is that you recall the patient regularly to replace the alveogel dressing, because it doesn't stay for very long. So make sure you recall them every 48 to 72 hours and replace the dressing until the healing has been complete. So give it 7 to 10 days before things settle down. And also to highlight that curettage of the socket to encourage bleeding isn't recommended, contrary to the popular belief. So dry socket is something you'll deal with regularly, and you need a thorough understanding of the diagnosis, management, and prevention of dry socket. So it's something uh, you can consolidate in other sessions. Osteoradionecrosis is also a healing defect following surgical interventions. It's seen in patients who've had radiotherapy to the head and neck region for cancer management. It's a topic in its own right, and we'll discuss it in year 4 in detail. Then medication-related osteonecrosis of the jaws uh, is a well-recognized condition now. 3 groups of medications: bisphosphonates, rankle inhibitors such as Prolia, and anti-angiogenic agents, which are used as an adjunct in cancer management. They may all be responsible for this complication. So make sure you read the full up-to-date guidance on the PDFC website so you completely understand this topic and are able to manage it appropriately. Infected cysts and malignant neoplasms involving the jaw bones may also present with pain. So infected radicular cyst, for example, is a classical one. Similarly, malignant neoplasms of the bone. In terms of specific infections, osteomyelitis, which may result as a complication of periradicular infection, trauma, uh, or it may be related to specific types of bacterial infections such as actinomycosis. So osteomyelitis is inflammation of the bone involving the medullary spaces, and there are a variety of presentations of osteomyelitis such as acute, with or without suppuration, um, chronic osteomyelitis, and then specific types of osteomyelitis related to bacterial infections such as actinomycosis and tuberculosis. And again, it's a topic in its own right and merits a separate discussion. Finally, fractures involving the jaw bones. So fractures of the maxilla, mandible, zygomatic bone obviously would present with pain. Pain would be a key feature, but then again, you will have a history of trauma in such cases, and the diagnosis is usually quite straightforward. Pain in the orofacial region may also originate from the maxillary antrum. The commonest uh, disease associated with the sinuses is sinusitis, which is basically an inflammatory disorder. Um, Even though sinusitis can affect all 4 paranasal sinuses, that's the frontal, sphenoidal, ethmoidal, and maxillary sinuses, but maxillary sinusitis is the commonest, and it presents with pain in the midfacial region, which is intensified by a change in posture, such as bending forward or lying down. If you take a radiograph, what you would see is that the normal outline of the maxillary antrum, which is completely radiolucent and black, becomes hazy with presence of inflammatory fluid. Obviously, this is not a radiograph, but if you take an OPG, you should be able to identify uh, haziness or opacity of the maxillary antrum unilaterally or bilaterally. And if you are able to exclude dental disease, then you can refer to their GP with confidence. Um, Malignant neoplasms of the maxillary antrum uh, can also present with pain, and again, a radiograph such as an OPG would help you identify lesions involving the maxillary antrum. Several salivary gland diseases may present with pain. We'll just talk about the more important ones here. Acute sialoadenitis, that is acute inflammation of the salivary glands. The classical example is mumps, which is a viral infection caused by paramyxovirus and primarily involves the parotid glands bilaterally. Um, Ductal obstruction as a result of salivary stones, which is known as sialolithiasis, presents with mealtime swelling and pain. And in most cases, obviously, this is quite a large stone and is very obvious on clinical examination, but even smaller stones can be identified by placing your finger in the floor of the mouth, and you should be able to feel any stones should they be present, and you can confirm their presence further by appropriate radiographs such as lower occlusals and OPGs. And once you've identified these, you can refer the patients to secondary care. Removal is usually quite straightforward, and most stones can be removed surgically in under 15 minutes. Obviously, there are other options of removing the stones, such as lithotripsy and Domia basket. You can read more about it. Malignant neoplasms of the salivary glands uh, can also present with pain. Uh, the more important ones are adenoid cystic carcinoma, which has classical perineural spread, squamous cell carcinoma, and carcinomatous changes in pleomorphic adenoma. Advanced Sjogren syndrome can also present with pain. So remember primary, secondary Sjogren's, its association with autoimmune disorders, xerostomia, xerophthalmia, and the increased risk of lymphoma in Sjogren syndrome. And then involvement of the salivary glands in HIV can also present with pain, and you can read about more about these topics separately. And just to highlight that certain disorders of the salivary glands are not associated with pain, so mucoceles, ranula, etc. normally are not associated with pain. Similarly, sialosis does not present with pain. So whilst it's important that you recognize uh, disorders of the salivary glands which can present with pain, equally you should also be aware of uh, salivary gland diseases which are not associated with pain. As you would know that nerves are responsible for conduction of impulses related to various types of sensory stimuli, including pain, and therefore nerves are involved in pain perception from any source. However, if the source of the pain is the nerve itself, we label the pain as a neuralgia. So in other words, we can say neuralgia is a pain of nerve origin. So in the head and neck region, there are a variety of primary and secondary neuralgias. Primary neuralgia implies that the pathology originates in the nerve, and two types of primary neuralgias in the head and neck region are trigeminal neuralgia, which is the most common and recognized, and VAGO-GLOSSOPHARYNGEAL neuralgia. And secondary neuralgias imply that the pathology originates elsewhere in other tissues and secondarily involves the nerves. And there are a number of neuralgias, secondary neuralgias, which involve the head and neck region, and we shall discuss these in the following slides. Trigeminal neuralgia is the most recognized neuralgia in the head and neck region, and although historic accounts have existed from the times of ancient Greeks like Hippocrates, John Fothergill was the first to give an accurate account on trigeminal neuralgia in the UK. In 1773, he presented a paper entitled On a Painful Affliction of the Face before the Medical Society of London, which is now the British Medical Association. Trigeminal neuralgia isn't that common. The annual incidence is 4 to 5 per 100,000. Obviously, these figures have been investigated on a limited scale, but these do give you a sense that trigeminal neuralgia isn't very common. What causes trigeminal neuralgia? Generally, it's regarded as an idiopathic condition. However, some patients may reveal evidence of uh, vascular compression of the trigeminal ganglion and the main rootlets of the trigeminal nerve. So, for example, an anomaly of the superior cerebellar artery may be compressing on the trigeminal ganglion and producing symptoms of trigeminal neuralgia. That is one possibility. Trigeminal neuralgia may also develop as part of the complications of multiple sclerosis, which is a demyelinating disorder, and something we'll discuss in a bit more detail in the later slides. Uh, but in summary, trigeminal neuralgia is regarded as an idiopathic condition. However, it is important to rule out central vascular compression using MRI scans, and we'll discuss this in a bit more detail in the diagnosis of trigeminal neuralgia. We shall now discuss the clinical presentation of trigeminal neuralgia. Fifth decade is the commonest age of presentation, and it's more common in the females. Trigeminal neuralgia is unilateral in up to 97% of the cases. Bilateral involvement with trigeminal neuralgia is quite rare, and usually a specific branch of the trigeminal is involved at any given point in time. So at the point of presentation, the patient may experience pain related to the right inferior alveolar nerve or the right infraorbital nerve. And in terms of the character of pain, it's very intense, in fact one of the most intense pains. And historically, when treatments weren't available, people would even resort to suicide because of the intensity of pain. So the pain is very intense, sharp, shooting, electrical in character, and occurs in bouts. That's its paroxysmal, and each bout of pain can last from a few seconds to up to a minute. Some unique features with trigeminal neuralgia. Firstly, the pain does not seem to disturb the sleep, so it doesn't awake the patient at night, and also it doesn't respond to routine analgesics such as paracetamol, non-steroidal anti-inflammatory drugs, or even opioids. Pain is often initiated by touching an area on the face, which may be around the cheek, close to the lower lip or the chin, and these areas are known as trigger zones, where the slightest stimulation may trigger an episode of pain. And interestingly, these trigger zones are located outside the area of pain distribution. So say if the pain is related to the right inferior alveolar nerve, the trigger zone may be located close to the corner of mouth, which isn't strictly within the area of distribution of the inferior alveolar nerve. So these are some of the unique features, and therefore patients may avoid washing their face or shaving. So some of the pictures you might see in oral medicine atlases may show a male who seems to have shaved on one side and avoided the other side. So just highlights the point that even the slightest stimulation may trigger an episode of pain, to the extent even a strong wind could trigger an episode of pain. So these are some of the more salient features of clinical presentation of trigeminal neuralgia, and you can read further about these in the textbooks. The diagnosis of trigeminal neuralgia requires a comprehensive medical history. Few things are important in the history. Firstly, the character of pain, that is electrical shocking pain occurring in bouts and lasting for a few seconds to up to a minute. The presence of trigger zones, the fact that the pain does not respond to routine analgesics and does not disturb the patient's sleep. So these are some of the important elements in the history. And clinical examination and routine dental radiographs, including an OPG, may be done primarily to rule out local disease, especially dental disease. You are not going to see any specific signs related to trigeminal neuralgia on clinical assessment or radiographs, and it's primarily done to exclude local disease. Local anesthetic injections have been administered traditionally in the diagnosis of trigeminal neuralgia. Just remember, any type of pain would respond to local anesthetic injection, whether it's due to pulpitis or local infection or, say, for example, dry socket. But the purpose of the local anesthetic injections is to localize the pain to a specific branch of the trigeminal nerve. So for example, if the patient complains of pain in the region of the right lower lip and chin, you would first administer a lower right mental nerve block, and if the pain subsides, then that would imply that the right mental nerve is involved by trigeminal neuralgia. If the pain is not responding, then you would go on to administer a right inferior alveolar nerve block, and if the pain subsides following the nerve block, then that would imply that the entire right inferior alveolar nerve is involved. So the purpose of local anesthetic injections is primarily to localize the pain to a specific branch of the trigeminal nerve. Finally, MRI scans. MRI scans remain the gold standard in the diagnosis of trigeminal neuralgia. Firstly, they would rule out any mass lesion in the brain, such as a tumor or a cyst. And then secondly, an MRI scan would help you identify any vascular compression of the trigeminal ganglion in the brain. And obviously, you're not going to perform MRI scans. That would be done following your referral to secondary care as deemed appropriate. The treatment of trigeminal neuralgia, there are a variety of options available, but medical treatment with anticonvulsant medications remains the mainstay of treatment for most patients. There are a number of medications, and I'm not going to go through all of those. I'll just highlight a couple, and then you may want to consolidate your knowledge further by reading about individual medications in your self-directed learning. So the most popular medication historically has been carbamazepine. It's an anticonvulsant drug which targets rapidly firing neurons by blocking sodium channels in these excited neurons. Not only carbamazepine is used for trigeminal neuralgia, but it's also used in the management of epilepsy, chronic pains, etc. There are a number of side effects you may wish to consider when prescribing carbamazepine, because it's one of the drugs which is available in the dental national formulary. So as a dentist, you can prescribe this drug. Usually a dose of 100 to 200 milligrams is used in the initial stages, and if the patient responds, that is also diagnostic in addition to being therapeutic. Carbamazepine can cause dizziness, so you don't want to prescribe it, for example, to a lorry driver driving long distance for their work, and it also suppresses blood counts, so regular monitoring of blood counts is essential. Another drug, which is gabapentin, which is also an anticonvulsant medication, has increased in popularity over the last 10-15 years, and gabapentin acts by blocking the calcium channels, and also there is the possibility of using baclofen, which is a skeletal muscle relaxant, and in combination with carbamazepine or gabapentin has offered promising results. And there are other medications available as well, but the key point to remember is that medical treatment remains the main line of management of patients with trigeminal neuralgia. A variety of operative treatment options also exist for the management of trigeminal neuralgia. Some of these treatments are no longer used. They're mainly historic in nature. These included alcohol injections, because alcohol is a neurolytic agent, and central and peripheral injections of alcohol, that is injection either in the main rootlets of the trigeminal nerve or the trigeminal ganglion, or peripherally on the face and the oral cavity, were used for treatment of trigeminal neuralgia. However, the recurrence rate was quite high. Within 3 to 6 months, most patients would have a recurrence. Similarly, glycerol has been used, and I've had some experience in using peripheral glycerol injections. Glycerol acts slightly differently to alcohol because glycerol causes dehydration of the nerve fibers and impairs nerve transmission, thereby leading to resolution of the pain from trigeminal neuralgia. However, Again, the recurrence rate is quite high, and within 6 months to 1 year, most patients would have a recurrence. Then we also used to do neurectomies, that is sectioning of the nerve, either peripherally by oral surgeons or centrally by neurosurgeons. Just be familiar with this term rhizotomy. Basically, any nerve destructive procedure is a rhizotomy, whether it's done with surgery or radiation or electric current heat damage. So central or peripheral neurectomies were done in the past. And finally, cryotherapy, that is freezing the nerve. That was a popular option until the turn of the millennium. And since then, I don't know many centers who still do cryotherapy for trigeminal neuralgia. So basically, for example, if a patient presented with trigeminal neuralgia related to the right infraorbital nerve, you would surgically expose the nerve, freeze the nerve in 2 cycles, and then suture up the site. And cryotherapy would give pain relief again for 6 months to 2 years on an average. So these are some of the historic options for operative treatment of trigeminal neuralgia. In contemporary practice, microvascular decompression, radiofrequency thermal coagulation, or gamma knife radiosurgery or gamma knife therapy. These are some of the more popular contemporary treatment options for trigeminal neuralgia, and we shall discuss these uh, in a minute. So in patients with trigeminal neuralgia where there is evidence of central vascular compression of the trigeminal ganglion or its main rootlets, microvascular decompression remains a popular option. So this procedure is done by neurosurgeons and involves either the use of a balloon, which is placed between the anomalous vessel and the trigeminal ganglion, and the balloon is inflated to lift the vessel away from the trigeminal ganglion, or it may involve the use of a sponge pad, which is placed between the blood vessel and the nerve to decompress the nerve. So this is one of the popular options of operative management of trigeminal neuralgia. Another option for operative treatment of trigeminal neuralgia is percutaneous stereotactic radiofrequency thermal rhizotomy. So basically the procedure involves using a 100 mm needle which is passed through the skin, and the trigeminal ganglion is approached through the foramen ovale. Once the needle is in place and its position has been confirmed, the needle is heated to a temperature of approximately 75 degrees Celsius for up to 2 minutes and leads to thermal damage to either the trigeminal ganglion itself or one of its branches as required, and as a result it impairs transmission of all types of nerve impulses including pain, and consequently one could expect a resolution of trigeminal neuralgia. However, with this treatment there is a high recurrence rate, but still remains as one of the recognized options for operative management of trigeminal neuralgia. One of the most popular procedures for treatment of the trigeminal neuralgia in contemporary practice is gamma knife therapy or gamma radiosurgery. Basically, it's a non-invasive procedure which uses precise dose of gamma radiation to damage the um, trigeminal ganglion or one of its branches. So it delivers a focused dose of radiation to the target site. Even though the success rate is well over 80%, it does take a few months before the full effect of the treatment can be observed in patients. So for the first 3 to 6 months after the procedure, the patients still continue with their routine medication and only begin to taper it off after 3 to 6 months. So it can be done as an outpatient procedure, and it's the least invasive central treatment for trigeminal neuralgia. Uh, at the end of the presentation, I've included a YouTube link which provides a video demonstration of various operative treatments for trigeminal neuralgia to enhance your understanding. Another primary neuralgia in the head and neck region is the vago-glossopharyngeal neuralgia, and as the name indicates, it affects the tissues in the distribution of vagus and glossopharyngeal nerves. It's about 100 times less common than trigeminal neuralgia, and the presentation of vago-glossopharyngeal neuralgia is very similar to trigeminal neuralgia, except for the location. So any of the following regions may be involved by pain associated with vago-glossopharyngeal neuralgia, that is the base of the tongue, the posterior mandible, the ear and infraauricular areas, pharynx and tonsillar areas. The management of vago-glossopharyngeal neuralgia is very similar to that for trigeminal neuralgia, and the main option is antineuralgic medication, which we've discussed previously. We shall now look at some examples of secondary neuralgias in the head and neck region. So, intracranial or extracranial mass lesions. When we say mass lesions, we mean either tumors or cysts. So either tumors within the cranial cavity or close to the base of the skull, which compress on the trigeminal ganglion or one of its branches, can produce neuralgia-like symptoms. And if there is a clinical indication, then you may need to ensure that these possibilities are ruled out when investigating patients with neuralgic pain. Causalgia is a condition which results from trauma to the nerve. So, for example, if you were undertaking a surgical extraction of a lower premolar and you damage the mental nerve, during healing, the nerve tissue may develop into a disorganized mass, what we call a traumatic neuroma, and it can lead to neuralgia-like symptoms. Other examples of secondary neuralgias in the head and neck region are multiple sclerosis neuralgia, which leads to trigeminal neuralgia-like symptoms, post-herpetic neuralgia, neuralgia-inducing cavitational osteonecrosis, FREY'S syndrome, and we'll discuss these conditions in the following slides. And finally, as you know, HIV has a strong affinity for neural tissue, and one of the manifestations of HIV infection may be neuralgia-like symptoms following HIV infection. Multiple sclerosis is one of the most common neurological disease in young males, and 4 to 6% of patients with multiple sclerosis may present with features of trigeminal neuralgia. So if trigeminal neuralgia is picked up in young people, which is otherwise quite rare in young people, it is important for these people to be investigated for uh, multiple sclerosis because it can have several complications, and early recognition of multiple sclerosis is important. So MS is basically a demyelinating disorder of unknown cause. A possible explanation of this disorder is an abnormal immune response to human herpes virus type 6 infection, and this is something we discussed in viral infections of the human herpes group previously. Multiple sclerosis, in addition to trigeminal neuralgia, may present with muscle spasm, pain, extreme fatigue, speech, swallowing, coordination of movement may be affected, leading to ataxia. There may be a variety of pathological changes in the eyeball, including optic neuritis, diplopia, and there is a risk of permanent blindness. Bladder and fecal incontinence are also observed in patients. The management of multiple sclerosis is difficult, but steroids and monoclonal antibodies remain the mainstay of treatment. Atropine may be prescribed for bladder control and anticonvulsant medication for trigeminal neuralgia. So, just to summarize, that trigeminal neuralgia, particularly in young people, may be secondary to multiple sclerosis. One of the recognized type of secondary neuralgias in the head and neck region is the post-herpetic neuralgia, which follows herpes zoster infection or shingles, and pain lasting for more than a month after herpes zoster infection is labeled post-herpetic neuralgia. The neuralgia itself may be due to destruction of the large myelinated fibers of the trigeminal nerve by the herpes zoster virus. It's usually managed with a combination of drugs including ibuprofen, tricyclic antidepressants such as amitriptyline, nortriptyline, or topical application of lidocaine. And short-term acute episodes may also be managed with Antonox or nitrous oxide. Neuralgia-inducing cavitational osteonecrosis is quite an interesting condition, uh, and I've done some research on it. So basically, what happens is, uh, following bone surgery such as tooth extraction, removal of jaw cysts, sometimes the bone does not heal completely and develops a low-grade osteomyelitis, and uh, there are areas of bone necrosis, and this leads to uh, pain which is very similar to the pain of trigeminal neuralgia. A differentiating feature, though, is that unlike trigeminal neuralgia, which displays extraoral trigger zones, patients with neuralgia-inducing cavitational osteonecrosis have intraoral trigger zones where the slightest stimulation triggers an episode of pain. And if you take good quality periapical radiographs, you may be able to identify areas of uh, osteomyelitis as they appear radiolucent even after 6 months following the surgery. So, if you can identify this condition appropriately, a simple oral surgical procedure may be curative. So, uh, following an appropriate diagnosis, all you need to do is raise a gum flap, access the area of osteomyelitis in the bone, and curate it. And this simple surgical procedure, which you know you can mostly complete within 20 minutes, will spare the patient from unnecessary anticonvulsant therapy for life or from major operative interventions. So, if you can identify this condition appropriately, you can contribute significantly to the uh, interests of the patient and appropriate management. Frey's syndrome is also known as gustatory sweating or auriculotemporal nerve syndrome. So, surgical procedures involving the preauricular area, such as temporomandibular joint surgery or surgery involving the parotid gland, may damage branches of the auriculotemporal nerve. And 6 months to 2 years following the surgical procedure, sometimes the auriculotemporal nerve heals and some of its branches innervate the sweat glands in this area, and every time there is salivation, it is accompanied by sweating due to the new connections made by branches of the auriculotemporal nerve, hence the name gustatory sweating. Whilst the condition is not painful per se, it may be accompanied by a burning sensation in the periauricular area and can lead to social embarrassment. So the condition can be diagnosed obviously in patients with a history of a surgical procedure in this region. Um, the Target tissue can be coated with starch iodine, and following salivary stimulation such as consumption of food, one would expect sweating, which will turn the brown color of the iodine into blue-black color. So that confirms the presence of moisture due to sweating. So you can diagnose this condition, and it's just because it may be accompanied by a burning pain in the preauricular area. That's why we've discussed it here, and you can read more about this condition separately. Facial pain may have a vascular basis. Examples of vascular pains in the head and neck region include tension headaches, which are common and involve the frontal and temporal regions bilaterally, migraine, which involves the frontal, temporal, and periorbital regions unilaterally, more common in the females, particularly in the third to fifth decade. Migraine is often caused by vasoconstriction of the cerebral arteries, and pain is observed during compensatory vasodilatation of the cerebral arteries. Um, there may be prodromal symptoms such as visual hallucinations, vertigo, nausea, aphasia, and pain from migraine may radiate onto the face. And a third very unique category of facial pain with a vascular basis are cluster headaches, which are unilateral periorbital pains, um, and we'll discuss that in a bit more detail in the next slide. Cluster headache is a condition characterized by some very unique presentation. The pain occurs in clusters of weeks, and hence the name cluster headache. Generally regarded as idiopathic, there is some evidence to support that the condition may have a vascular basis, possibly mediated by abnormal hypothalamic function. Uh, it is most common in the third or fourth decade of life and has a very strong male predilection. So the male to female ratio may be as high as 14:1. It is characterized by very intense pain involving the periorbital regions and the eyeball, and the pains occur in bouts. So the pain is paroxysmal, like trigeminal neuralgia. However, the bouts of pain last much longer, 15 minutes to 3 hours, and most attacks occur during the night, mainly close to the middle of the night, hence the name alarm clock headache. That's another name for cluster headache. The pain is unilateral and involves the midface, especially the circumorbital region, and is accompanied by nasal stuffiness and lacrimation. And cluster headache may mimic a maxillary toothache. A variety of medications have been used to treat this condition, including sumatriptan, prednisolone, lithium, and calcium channel blockers. But it's quite a unique condition seen mainly in the males, so you shouldn't forget this one. Temporal arteritis is another type of vascular pain which may involve the head and neck region. It results from an autoimmune disorder which leads to vasculitis in the temporal artery. This disorder is commonly seen in women between 50 to 85 years of age and may present with intense aching and burning pain in the temporal region, and the pain may also radiate to the face. Uh, One of the most serious aspects of temporal arteritis is involvement of the retinal arteries, which may lead to permanent blindness. Therefore, early recognition and referral is essential to prevent this complication. Uh, in terms of the diagnosis, uh, temporal arteritis is marked by an increased ESR, and a definitive diagnosis can be established by a biopsy of the temporal artery, which can be done usually under local anesthesia. In terms of the treatment, the mainstay of treatment for temporal arteritis is systemic corticosteroids, particularly important to start these early to prevent the risk of permanent blindness. Pain may be labeled as psychogenic if, following clinical assessment and investigations, no organic cause for the pain can be identified. Generally, these patients are more challenging to manage. There are certain common features with different types of psychogenic pains. Firstly, there may be a history of depression or hypochondria, and patients may present with bizarre descriptions of relentless pain which does not seem to respond to any treatment. They may also give a history of repetitive visits to multiple clinicians and specialists without any resolution. The site, distribution, and duration of pain are often inconsistent and do not conform to a specific diagnosis. And generally, with different types of facial pains, tricyclic antidepressant medications remain the mainstay of treatment. Psychogenic pains may present in a variety of forms, such as facial arthromyalgia, so TMJ related pains, pains involving the entire face or a particular region on the face, uh, pain involving a single or multiple teeth, when we can label it as atypical odontalgia. Oral dysesthesias are a group of disorders seen more commonly amongst perimenopausal women, and they present with a burning sensation, most commonly on the tongue when it's labeled as burning tongue syndrome, or the entire oral cavity when it may be labeled as a burning mouth syndrome. It's important to rule out certain local and systemic predisposing factors with oral dysesthesias such as xerostomia and anemia, diabetes, which may precipitate symptoms of burning mouth syndrome. But in any case, with all these different types of psychogenic pains, uh, antidepressant medications remain the preferred long-term option for management. Patients with a history of psychogenic disease or depression may also present with fictitious ulceration due to self-harm, and again, it's important to involve the medical colleagues such as psychiatrists and the patient's GPs. Otherwise, these patients can be quite challenging to manage. I've included a review paper which will provide you with further insights into the management of facial pains, including psychogenic pains, and you can look it up on the last slide. And it's an open access paper which is freely available over the net. Another possible source of pain in the orofacial region is referred pain. So pain coming from other regions of the body. So for example, patients with uh, ischemic heart disease such as angina pectoris or during myocardial infarction may experience pain which radiates to the neck and the lower jaw. Similarly, pain originating in the nasopharyngeal region, the eyes and the ears may also radiate to the face and the oral cavity, and it's important to carry out a thorough assessment to make sure that you are able to identify pain originating in other sites of the body which is radiating to the orofacial region. And finally, facial pain may be associated with administration of certain drugs. Um, the most important example would be use of vinca alkaloids, which are used in the treatment of cancer. So these drugs, such as vincristine, vindiblastine, and vindicine, These zinc alkaloids are administered by intravenous infusion and may cause facial pain during their administration. So under these um, circumstances, the diagnosis should be quite straightforward. So in the end, we'll just try to summarize some of the key points. Firstly, always remember that local causes are more common and you're more likely to encounter patients presenting with pain due to pulpitis rather than cluster headaches, for example. So therefore, it's important that for each patient, you carry out a meticulous assessment based on a thorough medical history, clinical examination, supported by appropriate investigations before carrying out any irreversible procedures, in particular any tooth extractions, without justification. You may encounter patients in practice who insist that the cause of their pain is a particular tooth and want that tooth to be extracted. If following your explanation they are still not convinced, you may offer them to seek specialist opinion before any irreversible procedure is offered. Secondly, it's also important to exclude organic disease before labeling the pain as psychogenic. So you may have patients with a history of a known psychogenic disorder, but it's important that you do not directly label every pain as psychogenic. So for example, they may be presenting with pain due to pulpitis, which requires operative treatment, and labeling the pain as psychogenic, you may be unable to provide them a straightforward treatment which would resolve their symptoms. And finally, whenever you are in doubt, it's best to seek specialist opinion